Good evening, guys. Now I've got discussion B for you tonight. The title is Medicare Part D Subsidy Loss. Okay, this is a speech tonight. I'm going to share that with you as part of my presentation. So please enjoy. My name is Felicia, and I serve as a health system executive and a palliative care specialist in Northwest Pennsylvania. I'm here today because the termination of Medicare Part D subsidies, particularly the low-income subsidy extra help, is producing predictable, preventable harm across our communities. What appears on paper as an eligibility adjustment is in practice a destabilizing event with measurable consequences for health, safety, and system-wide cost. Ending Part D subsidy is not administrative housekeeping. It is a health shock, a financial shock, and a moral failure. A single letter can trigger a health crisis. Every week, older adults in my health system open letters informing them that their subsidy has been terminated. The reasons vary. A small Social Security cost of living adjustment, a missed renewal form, a spouse's modest savings, but the consequences do not. When subsidies end, a $2 copay becomes $50. A zero premium becomes 60 or more. A medication that kept someone stable becomes unaffordable overnight. These are not hypothetical figures. They are the numbers patients bring to their appointments, often with pill bottles half full because they are rationing what remains. The clinical consequences are immediate and predictable. Medicare adherence is extinguishingly sensitive to cost. When affordability collapses, health collapses with it. We see hypertensive crisis in previously well-controlled patients, heart failure exacerbations triggered by skipped doses, COPD, COPD flares, when inhalers become unaffordable, diabetic emergencies, when insulin is rationed. These events are not random, they are the direct foreseeable outcomes of subsidy loss, and they drive avoidable emergency visits, hospitalizations, and readmissions. The system wide impact subsidy loss is a cost driver. Subsidy termination does not only harm individuals, it strains the entire health system. Paramedics, see abandoned prescriptions and request for partial refills. Clinicians spend hours navigating prior authorizations and appeals instead of providing care. Hospitals absorb preventable admissions that erode margins and capacity. Families face, families face impossible choices between medications, food, and housing. We pay for subsidy. We pay for subsidy loss in dollars, in workforce burden, and in human suffering. Why subsidies end? Why the process is failing older adults? Subsidies often end for reasons that do not reflect true financial security. A small Social Security increase pushes someone over the threshold. A spouse's modest savings, often reserved for burial or emergencies, disqualify the household. A renewal form is misplaced or misunderstood. A state program changes eligibility of ability to pay. Older adults should not lose access to essential medications because of paperwork complexity or marginal income changes. The human story behind the policy. In my own health system, I have watched patients who were stable for years suddenly decline because their subsidy ended. One woman, a widow living on less than 1,400 a month, saw her inhaler copay jump from $3 to 48. She tried to stretch it by skipping doses. Within weeks, she was hospitalized for respiratory failure. Her story is not unique. It is a common, it is preventable. What Congress and CMS can do immediately. We need reforms that reflect the realities of aging, chronic illness, and financial fragility. I urge lawmakers to pursue the following: automatic referrals for beneficiaries who previously qualified, eligibility thresholds align with Social Security adjustments to prevent penalizing cost of living increases, simplified asset tests that do not punish modest savings, clear protective outreach when rules change or renewal is required, streamlined appeals processes that older adults can navigate without legal or social expertise, a national commitment to medication affordability as a fundamental component of Medicare's promise. These are not radical proposals. They are the minimum requirement for a human functional system. Ending a Part D subsidy is not uh, not a neutral act. It is a destabilizing blow that threatens the health and independence and safety of older adults. It increases avoidable hospitalization, burdens families, and drives up costs across the health system. We can predict these consequences. We can measure them and we can prevent them. I urge this committee to treat Part D subsidy loss as the public health emergency it is, and to act swiftly to protect the older adults who depend on those supports to stay healthy, stable, and alive. Okay, guys, that's it for tonight. I will see everybody tomorrow for shows.